You're watching City Channel 4, your window to our community.
So I want to introduce on my far left Jessica Peckover, who's here. She's talked to us before. She's with the jail diversion program and also involved with the crisis intervention training. And Officer Ashley Jay is with her today too. And they're going to talk mainly about crisis intervention training. A lot of you have seen it on the news lately. It's a big news item. And we've talked about that in our meetings before. So I'm real pleased they're here to talk about that. Thank you both.
Well, thanks for having us. Most of you have probably seen me before. I've worked with jail alternatives for about 9 years now. So I've been here and I've talked about jail diversion and jail alternatives in the past. I brought this picture because we're going to focus on CIT today, but I wanted you to have an idea of sort of where this all fits in. When we talk about jail diversion, there's like 5 intercept points, right? So if you look at this, I like the funnel because it helps to create the idea that we really want to intervene with people closer to the top of the funnel than down further. So the stuff we're going to talk about when we talk about CIT, it's an intercept 1 diversion strategy. So there are 5 intercept points. So that's what we're going to talk about tonight. So the intercept 1 would be the top of that funnel. So we're trying to get people earlier on before they even get in the criminal justice system. And once they do get in the criminal justice system, we still work at identifying them as soon as possible so that they don't have to penetrate it further. So for those of you who don't know, is about here is where we've started in Johnson County. We started in 2006, we started the post-booking jail alternatives program where people who've been arrested for whatever reason, they get booked into the county jail and it becomes apparent that there's some mental health and substance use disorder needs and they could be better served by community-based services. We've been at that for a very long time. We go in there, we have clinicians meet with them, we find out what their needs are, find out what community services they're eligible for. We work on setting up those services, transitioning them out. We liaison with the attorneys and judges to see if they'd be eligible for early release with the condition they follow through. And we follow them out in the community, make sure that those services get stabilized, make sure they show up for the court dates, and hopefully get their needs met in the community so they don't cycle back through the criminal justice system. So that's been going on since about 2006, and so you've seen the numbers. It's been in the paper that we went from about 180 average daily jail census to about 109 is our average daily population now. So we've made some headway at the post-booking point, and I've been sort of fertilizing the soil for many years now, trying to get the Intercept 1 stuff going, and now stuff is starting to happen. So when I say Intercept 1, I mean crisis intervention team, mobile crisis outreach. Intercept 3 is post-booking jail diversion. And often when people think about jail diversion, they think about that post-booking model once somebody's already been arrested. And those of us in the business of jail diversion are like, we want stuff way higher up at the top of the funnel. We want comprehensive and accessible behavioral health services in the community so people can get their needs met at the time they need them. And then we need crisis services, mobile crisis outreach, crisis intervention team trained officers, so that when somebody gets into crisis, we have diversion options. They don't even have to get charged. They don't even have to go to jail. So we're going to spend time talking about that today. And since it's sort of a newer model, I think that video is the best way to go about this. It gives you a picture of what's going on. So I'm going to show an 8-minute video that is about the San Antonio model, which many of our officers that have gotten trained so far have gone down to San Antonio. And then after the video, we'll talk more about what's going to be happening in Johnson County.
It's one of several police shootings involving people with mental illness.
18-year-old Keith Vidal struggled with schizophrenia. He wasn't violent. All they wanted was help getting him to treatment. Seconds later, the officer shot and killed him.
They murdered our son for no reason.
Another disturbing video that raises questions about the treatment of the mentally ill behind bars.
He would hear voices.
The extraction team restrained him. Minutes later, the 33-year-old was dead.
Jails are the #1 mental health facilities across the country. They house more mentally ill person versus any hospital, any psych facilities, anything. They're patients, not prisoners.
Mental illness is the only disease that when you're in a crisis, the cops are called. If you're having a heart attack, you don't call the police.
People with mental illness are being criminalized instead of being provided treatment.
These county jails and law enforcement, that's a public safety net. That's where you end up.
There has to be some sort of solution, some sort of help for people who are suffering from mental illness.
and become involved with the police.
Jeff was the youngest of our four. He was finally diagnosed a paranoid schizophrenic when he was totally out of control and very frightening. I would have to call the police on him. They didn't know what to do.
I would get calls all the time when I was on patrol for a person who was in a mental health crisis. I had no clue how to handle it. And I would just keep getting the repeat calls every couple days or every week to the same house, the same person. And I just accepted it that this person's just going to be a repeat caller.
We decided very early on that we needed to address folks that were nonviolent misdemeanor offenders that were truly being put in jail because of their illness. We knew that it was law enforcement that were first responders and that they would be the ones that would be in contact with individuals in crisis.
So we decided what we would do first is train law enforcement officers in the 40-hour crisis intervention training. So they're trained to recognize mental illness. When they come up on somebody that's got kind of strange behavior, they're not using their command voice and the command presence like they're taught in the academy. They realize right away that this person has a problem. We brought together a bunch of law enforcement officers from the sheriff and the San Antonio Police Department, and every one of them didn't want to be there. I heard things like, I'm a cop, I'm not a social worker, I don't believe in these hug-a-thug programs, and this is a bunch of BS.
Before I went through the 40-hour CIT training myself, I didn't have the resources on how to handle mental illness. Well, now, it's way different. You know, I have confidence that when I go into someone's home, if they are experiencing some type of, mental health crisis, that I can get them to the right facility, and then I may never hear from them again.
I'm a mother, I'm a sister, I'm a friend, I'm a voter, I'm a volunteer, I'm all these people. I contribute to my community, and I have a mental illness. My diagnosis is major depression with psychotic features, dissociative identity disorder, and panic disorders. I've done the presentations to CIT training. And I tell them, I want to be treated the way you want your mother to be treated if she was ever diagnosed with a mental illness. If I'm in a crisis, I'm having a crisis, and I don't understand what's going on around me.
Get back! Get back! Get down! Don't do it! Don't do it!
In incidents with people who have mental health issues, it's unfortunate to see the ones that result in the use of deadly force where an officer didn't have CIT training, and possibly armed with that kind of information, that kind of training, outcomes may have been different.
I never knew each morning when I got up what I might find. He began to talk about a fire in the garage. So I thought, would he, without knowing what he's doing, start a fire? How much danger is he in, and how much danger am I in? So I called the police and I said, I'm terribly frightened. When they arrived, I introduced them to Jeff, and in this case, they came in plain clothing. They weren't in police uniforms. Now, they could have handcuffed him, I guess, and pulled him out, but they are taught how different that person is that they're dealing with. So they began to talk to Jeff. If they can get the person that's ill to, in their own mind, they're cooperating, it's far less violent, it's better for the patient, and certainly it's better for our police.
When nonviolent people go to jail with mental illness, they say it's 3 or 4 times longer than a violent offender, but when they get released, if they're not hooked up into treatment, they're going to be right back in. There are so many people in their emergency rooms who shouldn't be there. The previous police chief here has actually kept data on how long his officers are spending in emergency rooms waiting for psych evals and medical clearance, 8 to 14 hours. He spent $600,000 a year in overtime. Now here at the Restoration Center, the law enforcement officers are in and out within 15 minutes.
What we have here at the Restoration Center is services patients who are in crisis, either walk in or brought in here by CIT. They recognize the patient's in crisis. They're not truly suicidal. They don't really want to hurt somebody. They just need help.
There are about 18,000 people a year who are brought mainly by law enforcement officers to this restoration center who used to go to jail or emergency rooms or put back on the street. If you're a taxpayer and really don't know a lot about mental illness, the fact that the public's a lot safer when these people get treated, and the taxpayer saves a ton of money. Over the last 5 years, we've saved about $50 million in taxpayers' dollars.
We want everyone trained because of the potential daily that someone's going to come across someone who's in crisis. It's not a matter of if, it's a matter of how soon.
We've been coming up on 6 years of existence, and we don't have a use of force on our unit, which means we've never tased anybody, we've never shot anybody, we've never hit anybody with an ASP. But patients, talking to them, we get the result we want in the end, and we don't have to force it on them.
You want CIT to respond because you're going to get the help that you need rather than be sent to jail.
The issues that police officers have with people who have mental illness is not unique to San Antonio. That's all over the country, all over the world. So any city that would decide to focus on this, put an emphasis on this, would certainly benefit from it.
I no longer thought, what if they have to shoot Jeff?
We save money, we improve public safety, and people can get functional again. I mean, why wouldn't you do this? It's really a no-brainer.
I love that last line. Why wouldn't you do this, right? It's a no-brainer. So in Johnson County, we're going to do this. And I know NAMI has, when I first started in 2006, I would get lots of calls from NAMI at that time saying, we really want CIT, we really want CIT. And the chiefs were like, no way, we can't afford it, we can't get the, now the chiefs are like, how many officers can I send? So this is good stuff is happening. So I just want to talk about what a CIT program is a little bit. When people hear CIT, if they even know what it means, it actually stands for Crisis Intervention Team. It's kind of wrong in the video, it says Crisis Intervention Training. It gets a little confusing. But CIT stands for Crisis Intervention Team, and then we add training onto the end. They often think of the 40-hour law enforcement training, but CIT International and the CIT Police Chiefs Associations, all those people will say that CIT really has a 5-legged stool. The 40-hour law enforcement training is one leg of the stool, but community collaboration is huge. That's another very important leg of the stool. They often say that CIT is law enforcement led, but community supported. It really cannot just be, if law enforcement, it's one piece of it. We get law enforcement trained and how to de-escalate. That's great, that's good. If we don't have all the other pieces, it's very short-sighted, right? We're just, we're not able to get the full impact of it. So community collaboration is very important. A vibrant, accessible crisis system is very key. When communities talk about jail diversion and that sequential intercept model we talked about before, they'll often say, start with CIT. If you have no jail diversion efforts in your community, start with CIT. So let's say, okay, we're gonna get all our officers trained in CIT. They're gonna go through the 40-hour training, and very quickly they're all saying, divert to what? Then, right? Like, great, you're telling it, we now understand somebody's mentally ill, they have a substance use disorder, they're just in psychosocial crisis, their dog died, they lost their job, their wife just left them, and what do I do with this person, right? I leave them where they're at, that's probably not a great idea. I take them to jail, or I go sit in the ER for 6 hours. So having that vibrant, accessible crisis system is key. So when we take officers down to San Antonio and they get to see the restoration center, and they're like, they get in and out in 15 minutes, the officer's like, okay, Jess, when are we getting that in Johnson County? So we'll talk about that shortly. We're working on that. Behavioral health staff training is another piece of the stool. A lot of times, again, we think that we need to train law enforcement in signs and symptoms of mental illness, but we forget sometimes to train the behavioral health system and how to effectively interact with law enforcement, how to handle people who have some criminogenic needs and criminogenic risk factors in their life, how to help them better understand how they interface with the criminal justice system in general. So what a lot of places will do that do the 40-hour law enforcement training is they'll set aside observer spots so that behavioral health professionals, they'll come in and they'll sit in on that 40-hour training. They see what the officers are learning. You start to develop a common language. When I first started in this job, I considered myself sort of multilingual. I had to learn, how do you do law enforcement speak? How do you do behavioral health speak? How do you do attorney speak, judge speak? And what the 40-hour training does is it starts people kind of develop a new language. You start to understand each other's business, understand what you're doing, and you have a concerted effort. We're kind of all on the same page, looking the same direction. So we want to make sure we include behavioral health staff. And then the fifth leg is families, consumers, advocates. That's a very important aspect to include in any CIT program. Mary has been involved in some of our work groups, probably 2 of them, I think. I keep inviting her to more of them, and she's gracious enough to join. But for multiple reasons, that's a key piece of this. Families and people with lived experience obviously know firsthand what these crises look like, where the barriers are, what things work well. They're also the driving force, right? Like everyone else, you're sort of doing this in your job, and some people look at it from a professional perspective, but the advocates, the families, the people with lived experience, they're the ones that, they have a personal stake in this, so they're often the ones that really project these kinds of projects forward. So we're trying to cultivate all of these and be mindful of all 5 stools in Johnson County. And I probably need to update this a little bit, but this gives a little picture of what's happening in Johnson County. We first started taking people down to San Antonio to get them officers through the 40-hour training. If you may or may not remember that Leon Evans, who was in the video, the CEO of Center for Healthcare Services, has come to Iowa a few times. He's come to Johnson County once a couple years ago. And I just thought, I'm just going to ask if we could just come and observe this CIT thing. And they said, sure, we'll open up a few slots, bring some officers down. I had no idea that it was going to be anything more than a one-time thing. But in May of 2015, so just a year ago, we took 2 Johnson County deputies and a Coralville police officer and a couple command staff from the sheriff's office, and we went down and they sat through the 40-hour training. And Major Steve Dalzall will tell you, like, he was a naysayer, but he drank the Kool-Aid. He went down there. We sat in on the 40-hour. We sat in just on that Monday of the CIT training. Then I went and we toured the facility, and he came back and started talking to the other chiefs and talking to elected officials and saying, you all need to go see this, and we need to do this here in Johnson County. So then in January, there was a group of 10 elected officials, key community stakeholders, went down and looked at this. 6 more officers went down, went through the 40-hour training. And we came back, and in February, we had a community meeting, and we pulled together all the people who'd been down to San Antonio, all the officers who'd gone through the 40-hour training, and then people started inviting their friends, so there were lots more people. The city manager sent in a letter to the president of the university, and everyone's inviting friends. So it turned out to be more than just people who'd gone to San Antonio, which turned out to be a good thing. We had a community conversation where we said, what did you see down in San Antonio? What was important? What were the standout points? And then we distilled that down to, out of those things, what do we really want to see here in Johnson County? And these 4 things are what came out of that meeting. That they said, we want to do the 40-hour training. Let's make that happen. We want to get all of our officers through it. And not just law enforcement. They want it fire, EMS, first responders, bus drivers. They're very excited. They want all the first touches to go through this training. And then out of the things that we saw in San Antonio, the things that we thought were really important down here, if we're going to train our officers in diversion, the things we want to have were a sobering unit that you saw in the video, some type of behavioral health access, triage, crisis stabilization type of center that officers could take them to rather than sitting in the ER for extended period of time. 15-minute drop off and officers are out the door. And then a low barrier shelter. For those of you who may or may not know, we've had a winter shelter starting at the winter of 2014, 2015, we had the first low barrier winter shelter, which basically meant you could be intoxicated and be at the shelter. You can't bring the party with you, but you can have partied beforehand and you can show up there. And we saw a lot of, they didn't do it for this reason, but what we got from that was good data about reduction in what they call vagrancy calls. Trespass, I don't even know what codes all fall under vagrancy calls. I could quiz Officer Jay here, but several charges fall under that. But they saw a 75% reduction in that year that we had that, right? So so this is what Johnson County wants to do. So what we've done since February is we've convened these 4 work groups, and actually the low barrier, or I'm sorry, the behavioral health access and the sobering unit groups have kind of meshed together because the idea is it would be a campus style thing, and so the discussions really we were all talking about the same thing. So we've mushed them all together, but we continue to meet monthly, and we're working on this. We're trying to figure out what it might look like, what all would go into sort of a campus model. The idea is that the sobering unit, the behavioral health crisis triage, and the low barrier shelter the ideal goal is that it would be in one physical footprint because there are lots of benefits pragmatically, but then also for the client and being able to do warm handoffs and do services that can perhaps serve them ongoing after they leave the crisis facility. And then we're working very hard to get the 40-hour training to go. We are going to do our very first training in March, the week of March 20th through the 4th of 2017 out at St. Pat's Church. St. Pat's has agreed to partner with us. And for the first one that we do, you saw in the video Officer Smarrow. I like to call him the mental health whisperer. He is phenomenal when they teach and when they do the role plays. I'm like, he should be training behavioral health professionals. He's quite skillful, and a lot of them are down there. They're very masterful in this de-escalation business. So we've asked 2 of their officers to come up and help us with our first one, because we're going to put 60 officers through each training, and our first one will be in March, and we want to do it well. They keep telling us you can't mess up the first one, so we're going to try really hard to do it well. We have a lot of officer buy-in. We now have 18 officers in Johnson County from the various agencies who've gone down and gone through the 40-hour training. So they're already starting to, I'm assuming the Officer Jay could speak to this, doing things a little bit differently, using some skills on the streets that perhaps the officers are always doing the good work. They're maybe just not as intentional about it or packaging it in the way that CIT does. So I think that's a general overview. So I'll stop and ask for questions, and then we can also, if Officer Jay would like to add anything, I will let her do so. Any questions yet? Yes.
If somebody's in crisis now, if a person is in crisis now and the family calls, can they request an officer who's been trained in mental health here in Johnson County?
That's a really good question, and I don't have an answer. Can they?
Yeah. We don't necessarily have one. We don't necessarily have one working on every shift, but if we do, they should know who those officers are, or they can ask the supervisors. The officers that are trained, I'll tell you, whenever I see a call pop up on the screen that looks like a call that my CIT training would be beneficial, I go to that call. And our supervisors are really good about saying, go anywhere in the city if your skills are needed at a different area, you need to go there. I've also been pulled off calls by my supervisor. I'm on the way to a car accident, and it's no injuries or anything like that. My supervisor will say, hey, someone else can take that. Why don't you go over here? And so they're good about making sure that we're going to those calls.
Because we have this family support group, and people come in crisis, and we talk to them about what to do in a crisis, and it's good to coach them then to request that this is a mental health issue. Can you send somebody who has training in that?
That's a great suggestion. Thank you. That's a great partnership to have with NAMI to let the families know that they can. That hadn't really occurred to me. We have been talking as we're planning this 40-hour training for law enforcement. I'm also in the process of planning the training that would be for dispatchers, because the goal in a lot of these communities that have CIT is the dispatchers are also trained to ask the question so they can figure out, is this a behavioral health call, so that they can be the ones that dispatch CIT. But while we're working on that, I think that'd be great if, as Ashley mentioned, there may not always be a CIT officer. We're not resourced up to that level quite yet that every shift might have one, but I think that'd be a good starting point. Thanks for the question. Any other questions?
We like questions.
I know, that was really easy, guys. I mean, I'll start talking about lots of other things, but questions are better.
I'd be interested in hearing from Officer Jay and her personal experience. Do you feel like this makes you a more complete police officer, and has it changed how you interact with people in more routine calls too, in addition to maybe where there's a psychiatric issue?
I honestly use this training every single day for mental health calls especially, but this training has been very beneficial for other calls too. There's been talk about there being a full-time mental health position available with Iowa City, and I'm very interested in that position. So I've been keeping an Excel spreadsheet of all the calls that I go on that are mental health related, and I bet it works out to be a call every shift that these CIT skills are used for mental health calls. Now, if I kept a spreadsheet of all the calls I use CIT, it would be almost every call. These skills are very, very beneficial, helping with talking to people, and it's just a new way to look at things.
I didn't even have to pay her to say that, right?
You know, I might have missed this. I'm sorry, I have more questions. But San Antonio talked about having a drop-off center. Like you get the person individual and then 15 minutes and it's a drop-off. Is something like that set up here yet, or in the?
Well, not yet. That's those. Maybe I probably wasn't very clear. I talk fast. Those 4 work groups that we're working on right now. We're looking at, and we don't really have a name. So that's essentially the restoration center that they referenced in the video is what we're looking at doing here. Some sort of 24/7 law enforcement friendly drop off. And of course, law enforcement wouldn't be the only customer, right? Like other people could just bring themselves there in crisis rather than going to the ER. But the idea is that we would have some sort of campus-style model where there would be a crisis triage point. Come in, we'll triage. Do you need a sobering unit? Do you need to go into some psychiatric crisis observation beds? Are you, homeless folks who maybe aren't in a place of recovery now, or somebody who's experiencing homelessness that they don't necessarily feel compelled to achieve sobriety or maintain sobriety, but they need safe place to stay for the night so they're not getting arrested for trespass. We would have the low barrier shelter option. And again, the idea is that it would all be in one place. So from the user perspective, you don't have to figure out what kind of crisis I'm in. The law enforcement officer doesn't have to figure out, is this mental health, is this substance use? You just take them there. We'll take over from there, let the behavioral health professionals assess the situation, evaluate, stabilize them there, and then make referrals from that point on. But that's in the works. It's very early. We're doing lots of planning and figuring out what the components would be, what the potential one-time costs would be, what the operational costs would be, who the people would be who might pay for that type of thing. So we're very early in the planning stages, but there are lots of stakeholders in the community who are participating in this, and there's a lot of support for it. I was just at a meeting this afternoon with Supervisor Carberry from the county, and he said, this is obvious, as you mentioned, it's gotten a lot of media coverage. KCRG actually, Mark Carlson went to San Antonio with us in May and got lots of, it makes some people nervous, like there's media sitting in on this meeting, act right, don't say things wrong. But I think it was a really great way to get the message out, right? So there's been lots of media coverage, and Supervisor Carberry says, I'm getting so many contacts, and a lot of elected officials have said this, people are contacting them that I haven't heard anybody say, like, this is a really bad idea. Like, no one is saying that yet, right? Everyone's saying this is a good idea. So the conversations are more like, what specifically would we need, and how? How do we make this happen? Yeah.
I had a question. The other thing they might want to consider is transitional housing for individuals as opposed to shelters, because I know from my own personal experience, being in a shelter can almost be more emotionally draining and stressful as being in jail, because I've been in jail also for 2.5 days. I think you might remember me, actually. That was about 2 years ago.
I can't confirm nor deny that information. No, you bring up a good point. So when we're looking at this crisis triage center, this is just kind of a friendly, quick drop-off place. Then, of course, we're talking about, we have all these fun visuals that Dr. Flom, a psychiatrist at the U, makes for us. And so there's kind of the inflow, law enforcement, mobile crisis brings to this drop-off kind of triage center where just a safe place where we can kind of assess the needs and have really low barriers to you getting in there. And then from that point, we will assess the outflow. Like, where do these people need to be going to? We have some crisis stabilization beds. One of the gaps that I've identified is step down and transitional, more not just emergency shelter, but actual housing. And so if you notice in the one circle, it's actually low barrier shelter / housing first. We're really looking at getting a housing first programming in Johnson County that would say, let's get you into a safe, stable permanent living environment, and then we can address your behavioral health needs. There's a lot of national movement around housing first. And as you mentioned, that the shelters aren't necessarily the greatest place for somebody to be who's experiencing a mental health crisis. So it's just not set up. So one of the things, even with low barrier shelter, which I wouldn't necessarily say is maybe the best place for somebody with a mental health crisis to be ongoing, but we have talked about that it would be open 24/7 rather than the way the current shelter is that you have to be out, from 8 to 5, which isn't a great place for somebody to be who's in kind of a mental health crisis. That when they discharge people there from the hospital or from jail, when there's no structure for that person, 8 to 5, then that's not always a great setting. So great input, and we're looking at that in all the different levels. Yeah.
There's one other. I know this isn't the same, but in St. Paul, Minnesota now, they have an urgent care for mental health. So it's just urgent care for people with mental illness or mental health issues. So I know that might be a red flag for certain people to go there, but.
Well, and that's one of the ways we sort of conceptualize this is like a behavioral health ER. You'll often hear, and I think Dr. Flom might have said this in the KCRG clip, that the ERs are a great place if you've cut your finger and you need sutures, if you've broken an arm, the ER is a great place for that. If you're in mental health or substance abuse crisis, the ER is not a great place for that. It's just, for so many reasons. For the other people who are there, it's not a great place for somebody to be in behavioral health crisis. It's not set up for that. So what we're kind of envisioning would be sort of a behavioral health ER, behavioral health urgent care, if you will. And hopefully, I mean, there's be a lot of public education around this to sort of shift from if you're experiencing a mental health crisis or a substance use crisis, that this is the place you would go rather than the ER. Which is a similar public campaign that we're working on with Mobile Crisis. I don't know if you all know that we now, for just a little over a year, we've had a mobile crisis outreach team in Johnson County that's run out of the crisis center, and law enforcement can use that as well. You have behavioral health professionals who come out 24/7. So even that takes training, right? Like if you called a therapist office right now and you got their voicemail, it would likely still say, if this is an emergency, please hang up and dial 911. We really want people to say, if this is a behavioral health emergency, please hang up and call the Iowa helpline, which will get you the mobile crisis outreach team. So we're going to have to do some of that same education when it comes to if you're in behavioral health crisis, rather than going to the ER, you could go to this behavioral health ER, crisis restoration center, whatever it is we end up calling it.
On the impact on the mobile crisis unit, I know in Davenport, they have peer support specialists. They only have one. Do they have peer support specialists? Because because they found that to be actually more useful, the peer support person, than the other professionals on the staff. Because people in crisis are like, hey, you've never been in this situation. You've never been in this crisis. You have no idea, especially, in the hospital, I had somebody. Yeah. I've had that officer sit outside, and I understand that that's a little scary. Mm-hmm. But this is only a temporary situation.
Sure. We actually have one I say we. I don't actually run the mobile crisis team, but the Johnson County mobile crisis team does have one peer support person on there. This is different. So to be clear, we have officers who are trained in CIT and crisis intervention team training. Then we have a mobile crisis outreach team, which is a separate thing. The officers might call the mobile crisis team. The mobile crisis outreach team is not law enforcement officers. And as of right now, we don't have like a co-responder model. Like some communities, Polk County has a co-responder model, and some have that. It's just like an option. If the officers, they use their CIT skills to sort of get somebody de-escalated enough to say, hey, can we have mobile crisis come out? Mobile crisis will sit with you for 3 hours and problem solve and resource referral and all sorts of things. So we do have one. I don't know if she's gone through the formal peer support specialist training, but we do have one peer on the team.
It might be helpful to have a peer that could be able to come out for every. Yeah. And somebody who's gone through the training, because the training really is useful and they give a lot of training.
Good, thank you.
So that's my input.
Yeah, thank you. Noted.
Having gone through the training.
Yes, thank you. There's one in the back.
Hi, this is for Officer Jay. I was wondering if you could share a story with us from your experience after having had CIT training. I mean, obviously, protect people's privacy and stuff, but I think it'd be interesting for us to hear what it actually looks like on the ground.
I think, gosh, I'm trying to think which story to share. I have a lot of good ones. I'll start with this one, and if a different one comes to me, I'll share that one too. We responded to a call. Actually, some other officers were dispatched, and it was one of those situations where I heard the call come out, thought I could be useful, and went over to it. She was walking away from the house. It was an assisted living house, and she was walking away, said she was suicidal, said she wanted to walk into traffic. I went over there. She was upset, talking. She didn't want to stand there and talk to me, and the other officers were very frustrated because she kept walking away. And my CIT training said walk with her. If she wants to walk, that's fine. So she and I went for a walk. I talked to her, asked her some questions, and figured out some things that she liked to talk about. She had stuffed animals. She liked to talk about her stuffed animals. She was telling me what her bedroom looked like. And by the end of it, she's like, okay, I don't feel like walking in traffic anymore, and I would like to go home. And so we ended up walking back to her house. Like I said, it was assisted living, so I felt comfortable leaving her there. And they were very grateful that that was the decision that was made instead of us forcing her to go to the hospital. And she was in very good spirits when I left.
And just maybe to add to that, like, I guess we've not really talked about what happens at CIT. And so I don't want to put you on the spot, but just to share, like, maybe kind of what the nuts and bolts of the de-escalation that they teach you are, like, maybe those skills.
Well, they do kind of go over mental illness and give us some ideas of what to talk to those specific individuals about, people that are seeing things that aren't there, or hearing things, or people that are depressed. And then we have specific things that we can talk to those individuals about. The biggest thing was they taught us how to talk to people, which you think is something that we should have been doing forever. That's what we do. We talk to people. But it's new, and that's been awesome. And they also, the biggest thing I took from it was mental illness is something that's, it seems like it's new. It's always been there, but it's new to talk about and to say this is normal. Everyone, it's not an uncommon thing. And they taught us some things like saying, are you suicidal? Before, officers are like, do you feel like hurting yourself? And that's a completely different question. So they taught us kind of knock down some of those barriers, I guess, on questions that are okay to ask. And to somebody that's going through something like that, that's not a crazy question. That's a good question to ask. How to talk to people is the biggest thing. Yeah. Am I missing anything?
No, that's pretty much
okay.
I was gonna add. I got to sit in when I went down there. I sat in for the 40 hours and I watched the whole thing. So I got to sit in on the role play. So this is another huge piece of CIT. At least the model that we're going to use is that they do role plays every day. And so officers, fairly type A. They're problem solvers. They're great. They're public safety stewards. And they come in there trying to solve the problem. They're trying to fix the situation. So it's fantastic. Well, as an observer, it's fantastic to watch. Day one, the facilitators of role plays are like, it's like they're grabbing onto the officers like, you're just building rapport today. All you're doing is listening. You're not problem solving. You're not asking if you can go to the doctor. You're not asking if you want to go to a safe place. You're just listening. So I mean, Ashley's alluding to it's the stuff that they already do, but now they're being really intentional about it. Like, okay, really right now, I just need to get information. I can say things like, you appear upset. I don't need to say like, no, walking into the street's bad and dangerous. Let's focus on keeping you safe. It really is starting just to say, I need to understand where you're at. Tell me about what's going on with you. I want to get some information. And then later, then we can get to that place of sort of problem solving the situation. But that was the coolest thing to watch as an observer. I could see day one, it's like they're on little harnesses. The facilitators keep pulling back like, no. Just all you're doing is asking open-ended questions. All you're doing is emotionally labeling or, mirroring and not doing any of the problem solving that you see later in the week. And so throughout the week, you can see them like really start getting more comfortable with that. And it's pretty cool because, I don't want to like toot our horn in Johnson County, but our officers that went through the role plays, I was like, oh, they made us proud. Like they were really good. The instructors down there are like, you've got good people up here. So we're starting at a good place. But I think it just helps them to sort of hone that and be really more mindful. And one of the officers, I asked them to sort of start sending me some CIT calls, like you just asked, so that I can use them for role play scenarios when we do our 40-hour training. And it literally made me giggle because I was reading the notes. And one of the officers actually documented one of the skills that they taught down there when you're dealing with somebody who's experiencing psychosis is, I think historically they'd sort of be taught like, oh, go along with the delusion, or if you think that they're, like you don't want to make them mad. But what they'll say is like, I believe that you are seeing that, or I believe that you're hearing that, and I don't believe it, but I want to see if I can help you. And like verbatim, that was written out in their call disposition notes, and I was like, it's making me proud. They're just using all those skills. So that was the long answer to your short question.
One more thing to add with that. One thing they taught us in San Antonio with this whole CIT response is that these responses take time. We are used to responding to calls and handling them right away. We're very efficient. The faster, the better, and then we can move on to the next. But these calls take a lot of time. It takes a while to get that person to trust you and to trust that you're not going to just fight them and take them to jail, that you're trying to take care of them and you care about them. And one thing that's really great is our supervisors understand that. I was on a call one night for close to 4 hours. There was nothing else going on. I felt comfortable taking that long, and we got things done that we needed to get done. Afterward, I talked to my boss. I'm like, hey, that was a really long call. That's normally not how we do things. Is that okay? And she said, yeah, absolutely. Take that long if you need to. If there's a lot going on and we need to wrap things up a little faster, we'll let you know. But if there's nothing going on, take as long as you need. If you need to take 8 hours, take 8 hours. So that was pretty awesome.
I'd be interested just in hearing whether, aside, in addition to verbal crisis intervention skills, if they talk about nonverbals like personal space and your positioning, and even it's sort of verbal, but how you use your voice, your tone of voice, and how you speak and your eye contact, and that. Is that all part of the training too?
Yeah, they talk a lot about that. We actually just did a training with officers and talked about CIT in an hour, which is very hard to do. But one of the officers talked about that, about not crossing your arms, about not crossing your legs, just how we are. I mean, the uniform is very intimidating to begin with. So smiling when appropriate and not acting, but being more open than we normally would. We're used to kind of just being guarded and thinking everyone is out there to hurt us, and in these situations, more than ever, we need to show that we're not threatened by this person, that we care about them and we want to help them. We've also talked about, we just had a speaker with autism. I guess I don't know why I'm pointing to you, but it was at that same training, and they came in and spoke for an hour about personal space with them as well, because we're pretty picky about our personal space, but some of those mental health calls are too. So that was interesting. Did that answer your question? Yeah. Okay.
And I'll add that that's another one of the officers that, actually a deputy that went through it, that very much stuck with him as well. He was on a call with somebody who had some post-traumatic stress issues and actually was a veteran, and he noticed that she was getting really paranoid about that his backup officer was standing pretty close, and he sort of pulled the other, it was discreet. He pulled the other deputy aside and just said, hey, give some personal space. And the woman calmed down, visibly calmed down. And he just talked about it. Like, was that uncomfortable for you? Like, I noticed, and she was like, yeah, I can't have people behind me, So they're being really mindful of that. And then they see, like, there was a visible de-escalation that happened just by giving personal space. So they do go over that, and they're all picking up on it and using it. It's pretty cool.
Her question was, do we ask about medication, or how do we approach the topic of medication? Yes, we do ask. That's one of the things we're trained in. We ask when's the last time they've eaten, when's the last time they slept, when's the last time they took their medication, what they're prescribed. We don't necessarily know what any of the medications are for, but sometimes it's a good way to figure into what their diagnosis is. Like, you're taking these medications, what are they prescribed for? And seeing a lot of times people aren't taking their medication, and that's why they're having this issue that we've been called for. So it gives us a place to start. And sleep and food and water obviously play a big input in that. But I think that was something before that we were shy about asking some of those questions. And now we know it's okay to ask about medication. It's not too personal. And everyone I've asked about it is okay with it.
This might be kind of a weird question, but what do you do if you get a CIT call and say the person happens to have drug paraphernalia or something in their home? Or have you run into a situation where somebody might be hesitant to call for behavioral health crises because they may have other stuff in the house? Like, what do you do?
I think it depends on the situation. We get calls all the time, mental health or not, where people have drug paraphernalia in their house. It depends on the officer and it depends on the situation. If somebody's calling because they're thinking about committing suicide, I go over there and I see paraphernalia. I don't care. We look at the bigger picture.
Yeah, And I would say that that response probably even predates CIT. You're going to see a lot of that, especially when we have there are some individuals that the law enforcement community is very familiar with, and they know that any of these acting out behaviors are really symptomatic of something else that's going on. So it's like, oh, you got a couple things, and okay, hand that to the detective. Just go ahead and empty out your pockets. We're just going to take care of this herbal stuff over here, because it really is about like what's the best outcome here. Is it really to charge somebody with paraphernalia or with possession of controlled substance? And as Officer Jay was saying, like, we really do have an administration here, from the county attorney's office to the chiefs of police, that are like, this is bigger than just like knocking heads and like you're doing something illegal. It really is about what's the best outcome. How can we promote public safety and community wellness, right? And it's by getting people the help that they need. And it's nice to see that we're starting to just see it, at the front line level as well as the command staff level. So we're getting there. It's not always perfect, but we're getting there.
What advice would you give to family members who see that either this person is losing control, a danger to himself or others? Because we teach this in family-to-family class, but I'd like to hear what you say from your perspective, what you see as that family members do that's positive or negative.
We can answer from a couple different levels. If you mean in terms of like formal intervention, I would encourage family use mobile crisis. We have really good mobile crisis counselors who are very skillful in de-escalating those interpersonal problems, right? Like just having a third party come in who can sort of separate, the family, that can have, that in and of itself can have very de-escalating impact. So that's in terms of formal intervention. I would say use that. I don't know how often family members are using that right now, or how much it's being talked about at NAMI, but use mobile crisis outreach. In terms of, are you asking also just in terms of like how family could interact with somebody who's in crisis? Is that what you're asking for feedback on, or what types of resources? You're asking how families could interact. I would honestly say not much differently than maybe how the officers would talk. I think it's harder because as family members, right, we're emotionally involved. We're vested in the outcome and our own safety and their safety, so it can be harder. But to really try those active listening skills rather than trying to get the person to do something, to do what you think they should do. Take your medications. You need to go to your doctor appointment. You need to go to the hospital. Really start with asking those questions and using those active listening skills. More PI is the acronym they use. That using those minimal encouragers, open-ended questions, reflective listening, emotional labeling. You appear to be really angry. Can you tell me more about this? When you say things like that, I feel concerned and I feel like I need to do something. And so just saying things in a way, so there are lots of, we say active listening, like Ashley was saying, you think we do good communication all the time. We don't, and especially when we're emotionally engaged and when we're family members, we're mostly like, you're freaking me out and I'm worried and I love you and I don't want anything bad to happen. Do what I say right now, right? So if you can practice just some of those active listening skills of just listening, trying to get information out of them, trying to figure out what they need, what's driving the behavior, what's going on, and which, if it's somebody who's actively psychotic, those types of things might not be as effective, right? Asking those questions, but there are still things that you can do. You seem upset. That must be really scary to think that that's happening. I wonder if there's something that we could do together. Is there something, so I'm giving a really quick overview, but having families at those meetings talk about things like that. What types of active listening skills have been helpful? What types of questions are helpful? What ways of asking the question are helpful? Is it useful just to say, hey, let's take just a 10-minute break and come back to this? Is that an option? So that's, yes.
From the police perspective, I would say don't hesitate to call. If it's an emergency, obviously call. But if it's not an emergency, you guys can call. Anybody can call us and talk. I've done some follow-up with parents of children. They're not children, they're adults, but they're kids that are going through mental health crisis. I worked with a dad for probably a week, and he and I just talked, and he honestly knew more about all the resources that they have than I did. So I learned a lot from him. But we're always here to talk to. If it's not an emergency, you can call in and see if a CIT officer is working, and we're more than happy to talk to you and kind of bounce some ideas off each other. If a CIT officer isn't working, you can request one to call you back, or they can send you on to one of our voicemails, and we'll, like I said, we'll gladly talk to you You might have more answers than we do, but we're learning, and this is a work in progress. So we're definitely interested in helping.
What you were just saying, I kind of wish I'd have known 6 months ago, because I never, who is Mobile Crisis Group? Who are they a part of? I've never heard of them, and I've lived here for 60 years.
Well, we just got it last February, so you're not that far out. You're not that far off. It's a new thing. We've wanted Mobile Crisis for a long time, but we just got it last year from the mental health region.
In one instance, I talked to the dispatch center. Nobody mentioned it.
No, so it's not dispatched through law enforcement dispatch. So that's all part of the education process too, is getting
and
even getting the officers aware.
In fact, I actually talked to at an occasion. I talked to a police chief, and they says, "We can't do nothing. We can't help you."
Right. You know? So Mobile Crisis, it's actually run through the Johnson County Crisis Center, just across the parking.
Nobody, evidently.
Right. So apparently not. So I can get, Mary, do you have I'm sure, are there like brochures right outside there with the numbers? Okay. Okay. Carrie has more. We can get you the number. 1-855-800-1239, I think, or something like that. It's too late now, but it'll happen again, but I think this is good. If NAMI doesn't know about the mobile crisis line, we're probably in trouble. And we have various challenges with officers. We just talked about it at our multi-agency training in January, and the officers who were in San Antonio with me and May were like, "We have mobile crisis?" It's like, I just talked to you about this 4 months ago. Like, it didn't sink in. So I don't know if that's right. It was close. We'll get you that number, but I think it's a whole new thing. So when I talked earlier about the public education thing, this stuff is new and different. And look, you do have it. 1-855-800-1239. I totally got that right the first time. Yes, and please share that information. We're trying to get it out with officers. I got good feedback. We need to include it in the roll call binders and all different things. So we're trying to get the information to the law enforcement community, to the provider community, to the ERs. But of course, we want family members and people who are experiencing crisis to have that number. We also, the region just started a warm line as well that is staffed by people with lived experience. So peers who've gone through the peer support training. I think that they've all gone through the training. And so we now have a warm line. So if you're maybe not in crisis, but you just need a warm person to talk to, that's available as well. So hopefully, I think Mary probably has that information and can get it out to you.
Like he was saying, it was related to me, and I spent like hours in the ER kind of begging to be admitted when I wasn't a threat to myself or others, and I wasn't a risk to criminalize anything. I was just in a crisis emotionally. And I spent my whole evening in the ER. If the mobile crisis thing would have been great to know about, because it happened on more than one occasion to where the hospital did finally admit me. But
hopefully now you have the number. Because the other thing I would say to that is that we also have 2 crisis stabilization beds in Coralville. Mobile crisis team they're the gatekeeper. Like they do an assessment to determine if somebody's eligible to go to those beds. So that can be dispatched just by a loved one, but also sometimes the ER. So it's unfortunate that none of these things happen for you, because the ER will also dispatch mobile crisis to come there, because it's like you said, somebody who doesn't really need to be admitted to inpatient psych, but needs a safe place to go for a day or up to 5 days, and to have some people maybe offer some resources or just have a place to kind of just be in a safe place for a while. And so we do have 2 of those beds in Johnson County, and now for future purposes, but mobile crisis is also available, and hopefully I think the number is getting passed around, so feel free to use those.
Again, sorry that it wasn't an option or used for your situation, but the officers, we are learning and we're using it more. I used it for the first time last week. 2 other officers were with me on that call. They were not CIT officers. They saw me use it, saw how well it went, and I'm confident we'll use it in the future. Also with our training, it's with a strictly mental health call, the options really seem to be leave the person at home or take them to the hospital. There's no other option, which we're working on. But mobile crisis is an awesome tool. The other night when I used it, I wasn't comfortable leaving her there alone, but she didn't want to go to the hospital. I didn't know if the hospital was where she needed to be. So I called mobile crisis. They came out, and they're even more trained than I am. And they said, yeah, she'll be okay staying home tonight. And she was. So, and it gave her someone to talk to. And I think she felt much happier after that too.
And mobile crisis will do a follow-up the next day as well. They'll do just a follow-up phone call from the crisis center. The crisis center call center staff will call. So it is just sort of a concerted effort. And of course, there are growing pains. You know, again, like, we've been doing that for a year. We have officers that are getting trained. And of course, as you can hear today, the officers who've gone through the CIT training, they're the ones who are using these kinds of things more. And then other officers see it. And officers that are CIT trained are like, oh, this actually works. And it's safe to use these other alternatives. So we just have to be patient with ourselves. This is a whole new system overload. We've done it totally different, 911 and ER for years, and now we're trying a new way. And we've had a lot of good experiences, and there are a few missed ones, which is certainly unfortunate. And hopefully, we get better at this as we go along. Yep, there are 2 mobile crisis counselors on 24/7. So there are 3 8-hour shifts. So always it'll be 2 on scene. There are times we might have one mobile crisis counselor go out if it's to if it was to Chatham Oaks, for example. If it was to a place that's staffed, that there are other staff there, maybe one counselor might go. But typically it's going to be 2 that go out. 2 people with behavioral health degrees. Yes, there have been. No? Oh my gosh, when we got back from San Antonio in January, I thought I should have had a press conference because I got called. The Gazette has done things, Press Citizen, the Daily Iowan has done a million stories on it. The North Liberty, what is it called? They're doing like a multi-series on it. The Solon, whatever it's called. I know I should be better at. So there have been lots of media around it. But of course, again, we're going to keep getting the message out. It's not perfect, and not everybody gets educated the first time around. So we'll keep the message going out. We're working on that. Yeah, Carrie Neblett from the Johnson County Crisis Center, I'm sure would love to come back and chat with you guys. She's such a champion for this, and she runs the mobile crisis outreach program.
Because I missed all of these paper articles and missed having this paper and everything, the people that are staffing this, you say they have their mental health counselors, and are they DHS paid? Who pays them?
That's a great question, June. So to be a mobile crisis outreach counselor, you don't have to be master's level. So you have a bachelor's. The requirement is a bachelor's degree with 5 years of experience in the behavioral health field, and your degree is in some sort of human services field. We actually have several psychologists on our team. Like, many of them are licensed, but the requirement is bachelor's level with experience or peer specialist. The funding comes from the East Central Mental Health Region. So for those that don't know, we're in a 9-county mental health region. So ECR region is paying for mobile crisis. Yep. So Johnson County Mobile Crisis covers Johnson County and Iowa County. Hillcrest is covering Dubuque, and then Foundation 2 is covering Lynn County and some of the rural counties. The contract is with Foundation 2, and then Foundation 2 subcontracts with the Johnson County Crisis Center. So I would say the region funds most of it. We've procured some funds from grant funding because we need more resources than what the region is funding. I don't think anyone anticipated. They tried to extrapolate and decide what our numbers would be based on Foundation 2's numbers, but Johnson County's wanted mobile crisis for years and years and years, and we just blew them out of the water, and it gets used quite frequently. The ER was using it a lot when Dr. Hamadi and Dr. Flom were in the ER, and so that's the answer. The ECR region is funding most of it.
From what San Antonio, the numbers, the savings for having, doing crisis intervention training in these mobile crisis intervention units and that sort of thing, the savings is tremendous. So I would think that would help with funding down the road too.
That's the hope. Cost shifting, yes.
I have a question for the officer. What is the
biggest change in your behavior since the training and before the and after the training with when you've been making on your regular calls?
Like, all your dirty little secrets.
Just communicating with people. Like she said, the more pie technique, different ways of talking to people, different ways of getting people to talk. That's part of the techniques that we learned, is getting them to talk to us, and instead of us talking the whole time like I'm doing right now, getting others to talk to us so we can help them help themselves. That's been the biggest thing, and I've used that on other calls. Like I said, I use my CIT skills daily.
Are you more confident with mental health calls now?
Yeah. Like I said before, there were things that we just felt we couldn't talk about. Like, are you suicidal? Do you feel like killing yourself? Do you have a plan? Those things were things that we were taught to ask. And I don't know how many times I've been told, yeah, I have a plan. This is my plan. It's like, okay, you're serious then. And I never would have asked that before. And sometimes asking someone, do you feel like killing yourself? They're like, yeah. But then when I ask, do they have a plan, that tells me a little bit more about how serious they are. Those kind of questions that I never would have asked before. And like she mentioned earlier, people that are seeing or hearing things that aren't really there. Before, we would have just gone along with it. There's a lot of funny stories about that, actually. But now we know that that's not the appropriate way to handle it. That's not helping them. That's not helping us get to a point that we need to be at with this person. And so now we can handle it a different way. And it's okay to say, yeah, I believe that you're seeing that, but I'm not. It's not the first time they've been told that. I think we're always scared that we're telling them something new, but we're not. So it's just helping us accomplish what we need to accomplish.
And I just add to that, obviously I'm not a law enforcement officer, but I work with a lot of them. And I think historically, that this population wasn't necessarily their favorite population to deal with. And I don't think because they didn't want to deal with this population or somebody experiencing crisis, but because they didn't feel like they could, they're like, if it's an accident, I know how to do this and I can fix the situation. If it's domestic, I know how to intervene and I can keep people safe. This was sort of an unknown. And I think that's what you heard Officer Smarrow in the video saying, is like, I never knew I could do anything about this. And so I think what Ashley's saying is, now I can now I'm learning, I can just talk to people and I can ask them questions, and that might actually get me to a solution. Whereas before I might have just been freaked out, I just didn't know, it's not like you have bronchitis, give you a Z-Pack and the problem's gone. Human behavior is a little trickier, and that can be uncomfortable for law enforcement who's charged with community safety, right? I have to make sure I stay safe, I have to make sure the person's safe, I have to make sure the people standing around are safe. And this was just an unknown variable. So I think that that's something that I have noticed that maybe they wouldn't identify, but what I notice is there's a higher level of confidence that I can just sort of sit with this and I can feel okay with doing this and not just say no, I don't want to deal with this population. And it wasn't because they didn't want to, it was just because they didn't feel very skillful around it. So I'm sort of speaking for them.
I was going to say that my own personal experience with one of my sons who was very psychotic. He was out in the country with his grandfather, and he thought there were black men hiding behind trees, and he had, my son John had guns. He was a hunter, so he got his gun, and he was going looking behind trees for this black man behind all the trees. And my dad, who had been in the military and had PTSD himself, went with my son, and they looked behind trees and looked behind trees until John got tired and said, okay, I'm done. And he came back and went to bed. But that's exactly opposite of what you're saying, because my son John was delusional, and his grandfather went with him on that delusion. So if he'd argued with him, I guess I don't know. I'm scared of that kind of thing. If I argued with this great big guy that's got a gun, what?
That's one of the things they talk to us about. Don't argue about it. Validate that what you're seeing is real, that you're seeing men behind trees. That's real to you. I don't see it, but I believe that you do. And one of the reasons they suggested doing this is because if this person does go to the hospital and they talk to the doctor and they say, I saw guys behind the trees, and the doctor says, no, you didn't. And they're like, yeah, I did. And the officer saw him too. So that's important for us to say, we don't see those people that are there. And they, like I said, a lot of times they're like, okay, because they've been there before. It's not the first time.
So if it was an officer situation, it would be different, but the whole idea is not to argue at that particular time.
Validate that what they're seeing is real, because it is 100% real to them. Just because you're not seeing it doesn't mean that they're not, you know? And like I said, it's 100% real to them. So there's no point in arguing because they are seeing it.
Well, that's part of the thing that comes up in our family support things too, is families are dealing with kind of thing. And so I guess the key is to say, yes, it's real to you, but it's not to me, and let's proceed.
Yeah.
And then those I statements, right? Like these all seem silly. Like we've talked about, I don't know, like therapist 101, like I feel when you, but to follow that up with like, I believe this, and that must be terrifying. I don't see it, but it must be terrifying. And it concerns me that you see them and you have a gun, because I'm afraid of what might happen. So I need to do something here, help, let's work together, because I can't leave you running around in dark woods with a gun. So let's figure this out together. And that's a lot of what you start to see the officers doing in role plays. Like, okay, the number of times they're like, they kept telling us, like, I just had to say, like, I'm here to help. What can I do to help? But it's amazing. They were out of role players last time I was down there, and I had to be a role player, which I hate doing. But I found it was really helpful. And I was thinking the officers should be role players too, because you start to then feel like, oh, that's really actually helpful. Like, I'm not even really actually agitated, but I'm very de-escalated when you say, like, yeah, that must be terrifying. And I'm just trying to figure out what I can do to help you. How can we work together on this? And I'm like, let's do that. Let's work together on this. So again, trying to decrease that confrontational approach. I'm trying to get you to do something, but it's really figuring out, I'm concerned. What can we do together?
We can't undervalue the empathy. I don't think, it's so important. There's not much you can do about the thoughts and the hallucinations or whatever, but if you key in on how they feel, which are very real. This must be really scary for you. I can tell you're really upset. Then that conveys that the officer, whoever's intervening, the family member, is really trying to understand, and that's bound to make people feel a little bit more comfortable, I think. So. Well, we're about at the end here. Any final questions? One more?
One problem is that maybe you're going to help is that people get in jail, then they come out, then they can't, the landlord won't give them an apartment, and the employer won't give them a job. And what are they going to do? And pretty soon they do something criminal because it's all that's left for them.
Yeah, you've been supportive of some people in that situation for a while, and that's appreciated. And that's absolutely what a lot of these components that we're looking at, and not even necessarily with people you are maybe familiar with, but I think of even the college students, right? 53% of our public intox arrests are college students. So if we have a sobering unit, you can go sleep it off for 4 hours. You don't have a charge on your record. You didn't have to call mom and dad and tell them you need bond money. You don't have a fine. A lot of this stuff is a good across the board. And you're also talking about the people with addiction issues that end up in jail. And in addition to the issue that they're already dealing with, now they have the legal thing. It's hard to get a job. It's hard to get a landlord. So I do think that this is going to be, again, talking about the funnel. We always want to do things closer to the top of the funnel. So if we can do a lot of prevention, all of those secondary consequences start to fall away as well. So thank you for bringing that up.
Okay, well, thanks so much, you two, for being here. We really appreciate it.
You're watching City Channel 4. On TV, online, on demand, on Facebook, and now on the go on your mobile device.